Hello, everyone. Today, our point of discussion is about Gummy Smile and its correction with the Daemon Appliance in combination with tags, its biomechanical perspectives and clinical outcome. So this is a patient who presented us with adequate gummy smile. There was irregularity of upper and lower front teeth. She was an 18-year-old lady who presented with mostly these two problems. She did not have any relevant medical history to be concerned about. When we looked into her photographs during taking of orthodontic records, we found out that there is adequate incompetency of upper lip, which shows that the upper incisors are proclined. And the second picture shows that she had good amount of gummy smile, which is about 6 to 8 millimeters. And not only anterior, but she is associated with posterior gumminess also. There is irregularity of upper and lower anterior teeth and proclination of upper and lower incisors. When you took a 45-degree view, we came to know that there is posterior gumminess, there is irregularity of teeth, there is deep bite, and there is significant anterior gumminess, which we need to correct. And it was the primary concern of the patient. The profile view showed that the chin prominence is adequate, but there is good amount of lip incompetency, which needs to be corrected. But the underlying skeletal the corrections needs to be adequate enough, because even if we are correcting gummy smile, we don't want the chin to become more prominent. So this is partly a skeletal problem as well as partly dental. So it's a relatively straight profile. When we looked at the intraoral views, we came to know that it's a class 1 molar and a canine relationship. The most important fact that there was crossbite in the premolars, apart from a persisting deep bite in spite of having a class 1 molar. The deep bite is significant because partly the gumminess is due to the extrusion of the upper incisors. When we looked at the occlusal view, we came to understand that there was a constriction of the upper arch, a V-shaped upper arch, and there was a lot of crowding in the upper as well as proclination of the upper incisors. The lower arch also had crowding and proclination, apart from a few dental fillings, which was done in the past. Now, when we took the radiograph, we came to understand that a significant finding was that the third molars are yet to be was impacted. In fact, they were not in the arch. Therefore, the terminal hinge at this point of time would probably be a second molar, even if you are intruding the upper arch. But banding and bonding of the second molars, that is from 7 to 7, is mandatory in order to get a good the stable vertical correction, which will stay over a long duration of time. So the third molars were out of the arch, hence they were not posing a problem. They needn't be extracted in such cases because the intrusion of the upper anteriors and the posteriors are basically what we want. And the third molars would never interfere with the auto rotation of the mandible or correction of the gummy smile. So the terminal hinge of occlusion here is the second molar. So what's more important is that you band up and bond up till the second molars are in place. We're planning to use the Daemon Appliance because we find it suitable for this case. And if you want to know about the importance of terminal hinge and its role in auto rotation of the mandible and the correction of gummy smile, you can go through this article written by us, which is published in a university journal, which will talk about orthodontic surgery like orthodontics. So when we decide to extract the third molars for auto rotation of the mandible, it's not that every case should go for 4 premolar extraction plus 4 third molar extraction, which is like an 8 teeth extraction, but we need to choose them wisely. We have 3 conditions. The first condition is that if the third molar is impacted, extraction is not required in order to get auto rotation and in order to correct the posterior gumminess also. But if you have the third molars in occlusion, and if you see that the auto rotation is happening, you can delay the extraction of the third molar at a later date. But if you see that the third molars are in occlusion with the second molars and auto rotation is not happening, then extraction is a must in this case. However, if you want to analyze this case, the implication of the third molar in this case is not significant as all the third molars are impacted. Here, we are supposed to strap up from the second molar to the second molar. But in a lot of cases, you will find this scenario in which this slide is going to help you give a judgment of what you should do at that point of time. So if you look into the cephalometry of this patient, we see that upper incisors and lower incisors are proclined. It's a class 1 molar and a canine relationship. It's a convex facial profile, and there is a lip incompetency associated with it. So you have an interincisal angle which is more, and a composite analysis shows significant findings, dental findings mostly, but the growth pattern of this patient looks average. So that's the tracing and the superimposition on the facial photograph, which suggests that there is significant amount of lip incompetency associated with this case. When we look at this the perspective and we find out the cephalometric values, it is significant because you see that the A&B angle is not too high, which means that there is not a significant amount of vertical growth pattern leading to clockwise rotation of the mandible in this case. Here there is significant amount of gumminess, but in such cases, the vertical growth of the ramus tends to compensate for the vertical growth of the mandible, and hence you don't get increased A&B in all cases. So every vertical grower or may not have high A&B. That's basically because the vertical growth of the ramus might compensate for the vertical growth of the maxilla. Now, in this case, you would find that the FMA is average also. The IMP is more, the upper incisor to NA is also high. So we net come to a conclusion that it's a class 1 skeletal base. The average growth pattern, there is proclination of upper incisors, there is proclination of lower incisors, and there is a convex facial profile. You also have to understand that the gumminess is mostly due to a maxillary anterior dental height, which is about 38, which is increased, and maxillary posterior dental height, which is not too significantly increased, but it is on the higher side. So how do we correct these cases? That's most important. That's the treatment planning. And you can quote the article by Chiolo Pike, which talks about molar intrusion with tabs, the key element to correction of anterior open bite and vertical excess patients. So you have to understand that this concept is based on the fact that if you intrude the incisors, you are going to be able to retract them significantly. And you will get a significant counterclockwise rotation of the mandible if you are able to intrude the whole maxillary segment from the second molar to the second molar. But in this case, you have to understand that this is not exactly what we are looking at. We are looking at only correction of the gummy smile, but we want to get a decent chin prominence, not improve it too much, which would give it a class 3 facial profile. So the treatment plan in this case is to extract 1, 4, 2, 4, 3, 4, and 4, 4 tooth number. Intrusion retraction, which would correct the gummy smile. We want decrowding of the upper and the lower incisors, but auto rotation of the mandible to improve chin prominence has to be kept under observation so that we don't want to do it too much. We need a bit of IPR in the lower because there is a good amount of Bolton excess in the mandibular anterior region. If you want to know more about hyperdivergent facial patterns and how to correct gummy smile, you can also go through this article by KJ Lee and Sun Jin Kim in Seminars in Orthodontics, which would give you an overview about what are the perspectives of gummy smile correction, which is not a scope for a short lecture like this. So the appliance that we are using in this case is the Daemon Appliance. Now, this is a semi-customized appliance. It's not like your regular MBT. We chose this appliance because of the variable torque options which it had. You have high torque, low torque, and standard torque. And it tends to work wonderfully well in combination with TADs and bone screws. The John Lin, Chris Chang are other people who are proponents of the system in combination with the TADs. So let's try out with this Daemon Advantage. So what is the appliance system? It's a passive self-ligation appliance system, and we are using the standard torque brackets. That's because, okay, we are planning to place a single screw in the interiors. We are going to discuss about that later on. The standard torque usually have a central incisor which is plus 14 degree and a lateral plus the 6 in the maxillary arch. So that's our choice of torque in this case, because we want to do more of an intrusion and retraction and not too much of torquing of the upper incisors. So that's our torque consideration. In the lower arch, it is the standard torque is -6 in the lower anterior and +3 in the canine region. That's our standard torque option in the Daemon Appliance. So what is the wire sequencing which we are planning to do? You have to understand that we want to start it with 0.01690 for 30 days, 0.18 SS, which was required for 35 days. And then you have 1925 90 for 60 days. And the main working arch wire is the 1925 SS, which would probably require more than a year's time. And we want to settle it out with the 0.1490, which will be kept for about 30 days. So the lower arch is about the 45 days of 0.1890, which was placed, 60 days of 0.18 SS, and then you want to place a 1925 90 and then to a 1925 SS for retraction of the lower incisors. So 90 for initial alignment, followed by stainless steel wire and rigid arch wire in a rectangular wire in a rectangular slot for retraction of the lower arch. So for the upper arch intrusion and retraction, we prefer a posted or a crimpable hook, which is usually inverted or may be kept upright relative to the placement of the mini implant. So this is a treatment progress. We have the screws that are placed in the upper arch, and we also have the anterior screws placed. Now you have to understand this concept well. We have two posterior screws that is between 1.6 and 1.5, and on the left hand side between 2.6 and 2.5 for retraction. But the anterior gummy smile component is corrected by the midline screw. You can see that it is covered with a soft tissue. Now here is a discussion which we need to do. That's an intrusion and the retraction process. You also would see that the lower arch do not have mini screws, because we believe the retraction was happening with good amount of anchorage control. Also, if you want to have good amount of auto rotation of the mandible, in those cases, you tend to prefer a couple of screws in the lower arch also. But as you understand that in this case, we are not looking at auto rotation much because the chin is quite prominent. We are looking at correction of gummy smile only. So a midline screw is probably enough in the upper arch. Now the midline implants are usually placed in the attached gingiva, but where should an exact midline implant be placed? It is placed in between the two central incisors, that's fine, but what should be the height of the midline implant? You have to understand that we cannot keep putting the patient under multiple surgical sessions. That's because it would reduce the patient compliance. So we need to calculate the amount of gummy smile that we want to correct. And then we want to place the mini implant 2 mm above that from the point of application of the force, which is probably the arch wire or the hook. Now, so the height of the screw placement from the point of application of force is equal to the amount of intrusion that is required, that is the amount of gummy smile you want to correct, plus 2 millimeters as a clearance. Now, in many cases, if you use this formula, you would find that you are placing the screw in the alveolar mucosa. In such cases, it is good to use a screw which does not have heads, which is does not have an attachment head. So you have headless screws available. You also have good systems like Vectortas and all, whose screw heads are so nice that they are comfortable even if they are in place in the mobile mucosa. So you also have to bring into consideration the type of screws, the quality of the screws that you are using it in the alveolar mucosa. Any other screws can be placed in the attached mucosa without any combination, but if you are using screws in the alveolar mucosa, you have to take care to see that they don't cause irritation to the soft tissues, which might be very painful for the patient. So use good quality screws basically. So what is the biomechanics of this system? The biomechanics of this system is based on the fact that it is the working archware is a 1925 SS archware. You have micro implants of 1.5 into 8 millimeters, and which is placed between 1.5 and 1.6. And you are giving a force which has a mild vertical component. And you have to understand that in a lot of our cases, we tend to invert the screw. In that case, the vertical component increases. Vertical component increase would increase the posterior intrusion component and therefore would aid in autorotation of the mandible. But here we don't want to keep the vertical component too high because we don't want autorotation of the mandible by too much or posterior intrusion by too much. So therefore the hook has been kept upright, but it is not a horizontal vector, but it has some amount of vertical component because we want to take care of the posterior gummy smile also. Now, what is the amount of force that is used? There were 180 to 200 grams of force is used, and that would bring about retraction of the upper anteriors, which would bring about a bit of posterior intrusion also, considering that there is a vertical component to this force application also. But this vertical component also brings about an extrusive component in the anteriors and an intrusive component in the posteriors. Now you want to correct the anterior gumminess also, so you have to add on another screw in the anteriors, which will give about a force of maybe 80 to 90 grams for the front 4 teeth. That's about 20 grams of force per teeth. Please try to keep the force at optimum levels because we want good amount of intrusion and retraction happening without root resorption. Okay, if you use unnecessary forces, you might get into a lot of complications. So intrusion of the whole arch and retraction of the anteriors is possible. So what do? We have a scenario like this in which we want to correct gummy smile with tabs. Most of the time you need to extract the third molars, but in this case, the third molar was impacted or have not erupted. So therefore it's out of the question. So if you're using a single midline screw, you opt for a single midline screw, what does it do? It causes a bit of anterior intrusion and it causes a bit of flaring of the incisors, which gains torque. So you can easily use a standard torque bracket. If you're using a plus 22-degree bracket, then it's too much of a torque in the anterior. So patient might complain at a later date that my teeth looks much more proclined. If you're using dual screws, okay, which a lot of proponents do use it, in that case, okay, you should use a plus 22-degree torque because in that case, you mostly get true intrusion. You don't get flaring of incisors. So depending on your armamentarium and depending on your choice, okay, you have to take into consideration what torque value you want to use, what type of forces you want to use in the anteriors. Okay, so Damon gives you both options. It gives you both standard torque option. It gives you, high torque option, low torque options. So it's a semi-customized system, a great advantage over the normal systems available, MBT systems available in the market. The inversion of the screws or to keep it upright is also depends on the amount of vertical component of force that you want to use it for posterior intrusion. That is probably a scope of another lecture. And we have already showed it in a couple of YouTube videos as to in cases where heavy intrusion of the posteriors are required. So in this case, we are planning to keep the hook upright. We want to use one screw, and we also want to use a standard torque bracket because a single midline screw causes intrusion and flaring of the incisors. So the next step is that, okay, the closure of spaces is not a big issue because any good orthodontist can do that. So what did we get at the end of the treatment? We had 4 premolars extracted and we finished with a class 1 molar and a class 1 canine relationship. That's great. We have to note that the deep bite is grossly corrected because we started with almost 100% deep bite, and now we have about 20%, which is within the acceptable range. We have a midline, upper and lower dental midline, which is perfectly on. The decrowding and correction of proclination has been done. As you can see that the axial inclinations of the teeth have corrected, and there's good seating occlusion in the posterior segment. So what happens in the upper arch? We see we have placed a bonded lingual retainer. We place it both in the upper as well as in the lower arch. So we have decrowding of the upper anteriors and correction of proclination, which is done. We have also developed the arch form. The arch form initially started with a V-shaped arch form, which was much more constricted. But here you have a U-shaped arch form, which is much more stable with maintenance of the intercanine width. In the lower arch, we have decrowding and correction of proclination of the lower anterior teeth also. And a bonded lingual retainer placed from premolar to premolar in the lower arch. So what is the correction that we achieved? That we can see that the lip incompetency at rest has completely gone, like how we started the case. Gummy smile is absolutely taken care of, and she has a consonant smile arc, and the smile looks absolutely peach perfect. That's a great advantage of TADS, which is able to correct these problems non-surgically, because at one point of time, okay, in the 90s and the early 2000s, we were, all these cases were going for surgery. And this is a non-surgical correction that we achieved. 6 to 8 mm of anterior and posterior gumminess corrected with TADS is probably a remarkable change that we have given to the patient. So the midline of this patient facial midline is perfectly on. You have a smile aesthetics, which is almost close to perfect. The 45-degree view shows that the posterior gumminess has been taken care of. You have to understand the importance of the biomechanics, because a lot of times a single anterior screw is not enough. You would find that your posterior gumminess persists if you're using a single anterior screw. So this combination of system is very essential to get a perfect smile or perfect outcome of results. At the end of the day, the profile looks perfect. The chin prominence is adequate enough and great, and it's a straight facial profile. So it's an orthogonal facial profile that we got at the end of the day. The lip incompetency, which was there initially, has been taken care of also. So what did the post-treatment OPG suggest? That we got significant amount of intrusion, as the gummy smile would suggest. The third molars have adequate space to pop out. That's great, but we might suggest extrusion of the extraction of the third molars, so that at a later date the vertical control is maintained and the correction is maintained. You also note that there is no root resorption even after 7 mm of intrusion, 7 to 8 millimeters of intrusion. That's great. So a suggestion of prophylactic extraction of 1.8, 2.8, 3.8, and 4.8 once the EDAP was advised. So the post-treatment cephalometry shows that good inclination of upper and lower incisors have been attained. The tracing shows that you have a good orthogonal facial profile. Class 1 molar, class 1 canine relationship, good nose to chin prominence, the E line looks perfect, and the skeletal format, which was class 1 to start with, was maintained. So what is the post-treatment evaluations that we got? We saw that the A and B has reduced a bit minorly. You have inclination of the upper and lower incisors, which have been taken care of. The IMP is absolutely perfect at 90, so stability is never going to be a problem for this patient. FMA is average, which was there. The nasolabial angle is good as of now. It has improved. Lower lip to E line is also close to perfect. So we have a class 1 skeletal base, average growth pattern, normal inclination of upper and lower incisors, and an orthogonal facial profile. So what is the component which corrected the gummy smile? Is maxillary anterior dental height, which is now 31 from 38, and maxillary posterior dental height, which reduced by 1 millimeters, because we didn't want too much amount of posterior gumminess to be corrected, or autorotation of the mandible. So that's how we started. We started with class 1 molar, class 1 canines, and then we had 3 screws in place in the interiors with upright hooks, and then we finished with the class 1 molars and class 1 canines with ideal overjet and overbite. So the anterior component had a deep bite, which was attended to, crowdings, which were attended to, and the midlines looks perfectly on. The traumatic bite, the constriction of the upper and the lower arch were all taken care of during the course of the treatment. So what are the comparison changes that we got? You see that pre-treatment she had incisors popping out, which is there is good amount of lip incompetency at rest. And at post-treatment, she had a perfect balanced facial format with absolutely no lip incompetency or no lip strain. So that's the change we got. Incisal show at rest had improved. The gumminess shows gross improvement. We had anterior and posterior gumminess ranging from 7 to 8 millimeters, which were taken care of during the course of the treatment. So we had a gummy smile which was taken care of. There's a maxillary anterior dental height reduced significantly by 7 millimeters, which aided in the whole improvement that we got at the end of the day. Now, the 45-degree view showed that the posterior gumminess was also taken care of. Anterior gumminess was also corrected. Inclination of the upper and the lower incisors looks pitch perfect, and the crowding was also taken care of. So the posterior change was about a millimeter or so. So the profile started with, although the chin prominence was fine, but there was a problem with lip incompetency, which led to convexity of profile. But then at the end of the day, there is absolutely no lip incompetency. And you can see the positioning of the lip change with respect to a vertical drawn from the nasolabial angle. So that's as good a profile that as you could have got. So the pre and post treatment comparison shows that the inclination of upper and lower incisors have been taken care of. At the end of the day, the interincisal angle and all these things improved. Good talked upper and lower incisors. So if you want to know more about such form of gummy smile corrections, you can go through this article written by us at the Journal of Indian Orthodontic Society, which talks about biomechanical and clinical perspective for correction of gummy smile with DME. That's the TAD transparatal arch modified systems that we use. Now we have modified it even more simpler way. You can follow the YouTube channel in which we post up multiple the case videos. You can also go through this book by Kwanchol Choi, which talks about biomechanical foundation and clinical orthodontics. That gives you a great idea about the minuscule systems. If you like this video, do subscribe us in YouTube so that you can get free education in orthodontics related to complicated orthodontic cases, specifically mini implants, Daemon systems, Invisalign, and other MBT systems also. You can always look into the website and contact us in these numbers if you want to know further about such forms of treatment. You can also follow us in Instagram, where we upload daily cases, okay, and keep you updated with the latest trends in orthodontics.